The 2026 guidelines from the American Heart Association and allied colleges define cardiovascular-kidney-metabolic, or CKM, syndrome. It is a progressive, systemic, multi-organ disorder where metabolic risk factors, chronic kidney disease, and cardiovascular disease actively drive the progression of one another. Historically, medicine treated high blood pressure, diabetes, and kidney disease in isolated clinical silos. A patient saw an endocrinologist, a nephrologist for kidney function, and a cardiologist for vascular health, resulting in fragmented care. This diagram illustrates the transition toward treating these conditions as a unified pathophysiological cascade spanning stages 0 through 4. The heart, kidneys, and metabolic systems function as interconnected physiological nodes. Dysfunction in one node actively accelerates failure in the others. The overarching goal of the 2026 guidelines is to move clinical practice away from reacting to symptoms, shifting the focus to proactive, interceptive primary prevention. Accurately staging patients on this continuum is now a mandatory clinical baseline. Identifying the exact stage dictates the precise moment for a clinician to deploy synergistic pharmacotherapy and halt disease progression. We begin at stage 0, which represents a baseline of no risk factors. Consider case 0, a 32-year-old female patient with a body mass index of 22, normal blood pressure, and optimal lifestyle habits. To qualify for stage 0, patients must meet the Life's Essential 8 cardiovascular health criteria. This includes maintaining metrics like a healthy diet, regular physical activity, adequate sleep, and normal blood glucose. To quantify risk at this stage, clinicians use the PREVENT equation. This tool replaces older, isolated cardiovascular calculators by integrating kidney and metabolic factors to accurately predict long-term outcomes. Looking at this PREVENT calculator interface, this patient's calculated 10-year risk for atherosclerotic cardiovascular disease is precisely 0.2. This chart compares total body weight loss percentages. Structured lifestyle modifications alone consistently yield the results seen on the left. Initiation of GLP-1 receptor agonist therapy, such as semaglutide or tirzepatide, drives the higher weight reduction seen on the right. Breaking down the physiological composition of that weight loss reveals a clinical caveat. While the majority of the reduction is fat mass, between 15 and 25% of the lost weight is skeletal muscle. Clinicians must prescribe resistance training concurrently with GLP-1 RA therapy to mitigate sarcopenia and preserve the patient's metabolic resilience. By addressing stage 1 adiposity with pharmacotherapy, clinicians can target the metabolic triggers that contribute to irreversible organ damage as the disease progresses. Stage 2 marks the collision of metabolic risk factors with chronic kidney disease. Case 2 is a 52-year-old female with a BMI of 34, type 2 diabetes, an eGFR of 62, and a urinary albumin to creatinine ratio of 45. To accurately stratify this patient's risk, we map these specific renal metrics onto the KDIGO heat map. Plotting her eGFR in the G2 range against a UACR in the A2 range pinpoints her directly in the moderately increased risk category. This structural kidney involvement dictates a shift in guideline-directed medical therapy. Clinicians must initiate ACE inhibitor or ARB therapy for kidney protection without waiting for the results of glycemic or lifestyle interventions. An SGLT2 inhibitor is then added to the regimen for its dual cardiac and kidney benefits. This addition is indicated regardless of the patient's baseline glycemic control. If the patient's metabolic and weight targets remain unmanaged, the guidelines outline the secondary threshold for layering a GLP-1 receptor agonist into this regimen. At stage 2, while lifestyle changes remain a core requirement, they are no longer sufficient on their own to prevent disease progression. Shielding the renal and cardiovascular systems now requires the immediate addition of synergistic pharmacotherapy. Stage 3 identifies subclinical cardiovascular disease. In case 3, we evaluate a 63-year-old female with type 2 diabetes and hypertension, who reports being completely asymptomatic. Hidden subclinical markers vault this patient past stage 2. Her coronary artery calcium score is 365, and her NT-proBNP level is 180. These stage 3 multipliers aggressively tip her clinical scale into the red zone. These markers define subclinical cardiovascular disease and pre-heart failure. A calculated PREVENT risk score exceeding 20% independently qualifies an asymptomatic patient for stage 3. This requires intense primary prevention protocols immediately, including the initiation of high-intensity statins and aspirin. The patient's baseline glycemic control must also be shifted to an SGLT2 inhibitor, specifically indicated here to prevent the progression from pre-heart failure to clinical heart failure. The absence of physical symptoms in stage 3 is a dangerous clinical illusion. Aggressive subclinical biomarker screening is the only definitive way to detect and halt impending cardiac failure. Stage 4 introduces clinical cardiovascular disease within the CKM framework. Case 4 is a 62-year-old male presenting with heart failure with preserved ejection fraction, new-onset atrial fibrillation, an eGFR of 37, and a history of percutaneous coronary intervention. This specific presentation represents terminal cascade point. Cardiovascular disease has clinically manifested alongside end-stage metabolic and kidney dysfunction. This chart visualizes the multimodal strategy required for treatment. The patient receives an SGLT2 inhibitor for both HFpEF and CKD, a GLP-1 receptor agonist for HFpEF symptom management, and a nonsteroidal mineralocorticoid receptor antagonist based on his renal indicators. Managing stage 4 requires integrated care coordination between cardiology, nephrology, and endocrinology to apply this regimen without triggering conflicting drug interactions. While stage 4 demands the most aggressive integrated medical management, arriving at this stage represents a failure to intercept the disease cascade during its subclinical phases. Adopting the 0 to 4 CKM staging continuum is a mandatory framework for evaluating all adult patients. Clinicians must dynamically track the PREVENT risk score longitudinally across a patient's lifespan, rather than relying on static, one-off assessments. Synergistic cardioprotective and renoprotective agents allow doctors to simultaneously shield the heart, kidneys, and metabolic system. The early deployment of these therapies acts as a roadblock, intercepting the timeline between the onset of risk factors and systemic organ failure. Mastering the CKM continuum empowers clinicians to transition from reactive disease management, providing the protocol needed to proactively preserve multi-organ function and save lives.